Hello, and welcome to Abbott Nutrition Health Institute's Strength Ambassador webinar titled The Impact of Nutrition and Muscle in Aging Polymorbidity, with a live recap of the 41st ESPN Congress. We will have two speakers today. First, Dr. Philipp Schutz. Dr. Schutz studied medicine at the University of Basel, Switzerland, and the University of Crenlin-Bicêtre in Paris. He is a board-certified internist and endocrinologist with special interest in clinical nutrition and broad clinical research interest focusing on the application, new developments of endocrinology, infectious disease, critical illness, and general medicine. He is currently head of medicine and emergency at the Medical University Department of Kanthospital Aarau. Second, Dr. Rafat Higazi. Dr. Higazi is Medical Director and Director of External Scientific and Medical Engagement at Abbott Nutrition. Dr. Higazi is a graduate of Mansoura University Faculty of Medicine, Mansoura, Egypt. Dr. Higazi has a Master of Occupational Health and Industrial Medicine, also from Mansoura University, and a Master of Public Health from the University of Pittsburgh. He is a graduate with a PhD in epidemiology from the School of Public Health at the University of Pittsburgh. We'll have two topics today. First, Professor Schutz will discuss the impact of nutrition, muscle in aging, and polymorbidity. Following that, Dr. Higazi will give us a recap of the 41st ESPN Congress, sharing some important details that we learned from this week's events. At this time, we will turn the program over to Professor Schutz to discuss with us muscle in aging and polymorbidity.
Welcome to the webinar. So today I will cover the topic how nutrition impacts on muscle in aging and what's the impact of polymorbidity on this. So my objectives today are to review the impact of aging and polymorbidity on nutritional status and muscle mass, strength and functionality. I will also discuss specifically the role of malnutrition and highlight recent evidence on the role of nutrition intervention to improve outcomes in various patient populations, including the ESPN polymorbid guidelines and the recently published EFFORT trial. So polymorbid patients are often characterized in the hospital by loss of appetite and weight loss, particularly if these patients are chronically ill and have weight loss for a long time, their risk for malnutrition steeply increases. So what is malnutrition? And you may be familiar with the new GLIM guidelines that have just been published in 2019 in ESPN in clinical nutrition. So the GLIM guidelines highlight that there is three main phenotypical criteria for malnutrition, which is either weight loss, low body mass index, or reduced muscle mass. And today we have also seen what are the main links between acute and chronic illnesses, sarcopenia, malnutrition, and then adverse clinical outcomes. And so the three main factors here seem to be first, inflammation and endocrine dysfunction. Second, also immobilization. And then third, we have disease-related anorexia. So the question really about disease-related anorexia is whether this is also a modifiable risk factor, and if we are active with nutritional treatment, can we have a positive impact on malnutrition, but also then on clinical outcomes. We also know that malnutrition is very frequent in the hospital. On this slide, you see patients from my own institution over a 6-month period. We have about 4,000 patients in the medical unit, so all medical inpatients. And when you apply a screening tool, such as the nutritional risk screening to these patients, about 30% of the patients have an increased risk of malnutrition, with about 20 to 25% of the patients actually having malnutrition. And we found when studying these patients that there is a high risk for mortality in these patients, but also risk for complications, for decline in functional outcomes is increased in these patients. And really, it's an important question, what can we do to reduce these malnutrition-associated risks? Is it efficient if we use nutritional support in these patients? Is it possible to reduce these risks in this patient population? So some people may think, well, loss of appetite is a biological response that we see in our pets, in our animals, in the dogs and cats, but also in our children. And usually if our child gets sick, we do not use any clinical nutrition in our children. But the reason and the difference between our children and the chronically ill patient is that the children, they can catch up with food once they feel better. But the chronically ill patient will have, over a long period of time, loss of appetite, and though he will develop the phenotype of malnutrition. So this patient really is different from our children, or also the biology. And so the question is, how can we be active in this patient to reduce the risks for malnutrition? So is loss of appetite a physiological response, or is it a therapeutic target? Can we do something about it? And is it possible to, by improving nutritional status, also improving clinical outcomes? So let's look at the clinical guidelines for just a minute. These are the ESPEN guidelines on nutritional support for polymorbid internal medical patients. And so you can see there is several statements regarding nutritional support. So first, the guidelines highlight that in the polymorbid medical inpatient population, it is important to use a screening tool to quickly and simply assess nutritional status and to flag these patients at risk for malnutrition. Second, it is important in these patients where there is malnutrition or high risk of malnutrition to start a nutritional plan and to use different strategies, also including ONS, to reach nutritional goals during the inpatient stay. Also, if ONS is not feasible or not possible due to maybe gastrointestinal failure, we should use then enteral or parenteral nutrition, parenteral particularly if there is gastrointestinal failure. The guidelines also highlight that we should use high targets for protein. So in the guidelines, there is protein targets of higher than 1.0 grams protein per kilogram per day for a patient. There is also importance to use other things like micronutrients, and there is other possible nutritional supplementation such as fibers, omega-3 fatty acids, glutamine, and other things. Importantly also, we need to monitor the nutritional parameters in patients during the hospital stay, and we should try to meet the goals of 75% energy and protein requirements in our patients. And finally, the guidelines also highlight that organizational changes are important. So nutrition is, of course, a team effort, and you need to organize your team with your dietitian, with your nurses team, with the physician, but also including the patient and his preference, and then you can have success with nutrition. Now, one problem about these guidelines, when you read them very carefully, is that in the end, the recommendations are not so strong. So there's a lot of recommendations, what you could do, but most of these recommendations do not have strong evidence behind it because there is lack of strong trial data so far to really support these guidelines. And this is the reason about 5 years ago we started the EFFORT project. So EFFORT stands for Effect of Early Nutritional Therapy on Frailty, Functional Outcomes and Recovery of Undernourished Medical Inpatients. And this is really a project asking the question whether the use of nutritional support in the medical inpatient population has positive effects on clinical outcomes beyond those effects that we already know on nutritional outcomes. This project has several steps. So first we did a meta-analysis looking retrospectively at data and trials that have been done in the past. We then, in a second step, came up with a treatment algorithm for polymorbid patients. And so at the start of the project, there was really no consensus how to best treat patients with polymorbidity, because the guidelines are more single organ focused. So there's cancer patient guidelines, there is renal failure guidelines, there's geriatric guidelines. But the polymorbid patients that have several organs failing, for these patients, there was really no treatment algorithm. So we came up with a consensus algorithm and then tested this in the randomized trial, which I will show you just now. So the project went on for 4 years, and I'm very happy that this summer we were able to finally publish our results in the Lancet, showing what the effects are of nutritional support on clinical outcomes in this patient population, and I'm happy to share with you these results. The study was done in several centers in Switzerland, so we had 8 centers, and at that point I also like to acknowledge and thank all these centers for their participation in the trial. So it was a long time and a lot of patients that were included in these different centers, and it was a huge team effort to really come to these results now. So what did we do? Well, we didn't use a new fancy algorithm actually, but we did what normally dietitians do in the hospital. So first, and I think this is very important, we did a screening in all these hospitals in order to early identify patients at risk for malnutrition. So during the trial, we used the NRS 2002, the nutritional risk screening, and we asked hospitals to apply this score as fast as possible when patients were admitted to the hospital, but no longer than 48 hours. We then included the patients and we defined individual nutritional targets in all the patients. So we had a caloric target, caloric requirement. So here we used the formula, the Harris-Benedict equation. We second also had protein targets, and we aimed for high amounts of protein in these patients. So 1.2 to 1.5 grams protein per kilogram per day. We also had micronutrient requirements. So all these patients received micronutrients. And for some patients with specific diseases such as short bowel syndrome or chronic pancreatitis, we also had some other specific nutritional recommendations. We also defined an algorithm how to reach these targets. So we had a 3-level algorithm, and dietitians could escalate the nutritional support in these patients from level 1, which was a basic oral level, oral food, to level 2, which was nutrition, enteral nutrition, to level 3, which was parenteral nutrition. Most patients could be managed on level 1. So most patients could be managed with oral nutrition, including the hospital food, by adjusting the food to patients' preferences, by using meals, snacks between meals, and of course also by using ONS, so oral supplements, which is a very efficient way to increase particularly the protein part of nutrition. So if a patient within 5 days would not reach at least 75% of these targets, then the recommendation was to escalate and to place the enteral tube into the patient to start enteral nutrition. Or in some patients with gastrointestinal failure, we then had to escalate to parenteral nutrition. So in the trial, we first screened patients on admission, and we had very broad inclusion criteria. So basically, any patient coming to the medical ward with a risk for malnutrition based on the nutritional risk screening, with an estimated length of stay of at least 5 days, and written informed consent could be included. We had some exclusion criteria, which were mainly based on whether a patient was coming from ICU or from surgery, patients already coming with nutritional intervention, patients in terminal conditions were not allowed to be included in the trial. So patients were then randomized to the intervention group, in which patients received nutritional support based on our treatment algorithm, or to a control group. So what's the control group like in a Swiss hospital? So basically, these patients could choose from the whole food that is provided in the hospital, but we did not aim to reach any goals in these patients. So if the patients felt sick and didn't want to eat, had loss of appetite, we tolerated this, and he was not asked to do any intervention to increase the food intake. So this part of the trial, the intervention was non-blinded, because it was not feasible to blind the team whether patient would receive nutritional support or not. However, we did blinding of our outcomes at 30 days, and so the outcome assessment of the trial were blinded. We screened about 5,000 patients, about 2,000 were not eligible, and 1,000 patients refused participation. So we had a bit more than 2,000 patients that were finally included in the trial and also used for analysis. The patients were typical patients from medical ward, so they were about 72 years old, male and female about 1-to-1. We had about 30% with a nutritional risk screening of 3 points, about 30% of 4 points, and about 30% had more than 5 points or more. So about a third of the patients really had a high risk for malnutrition. In regards to admission diagnosis, we had the typical spectrum of medical inpatients. So infection was very common, cardiovascular disease, cancer, lung disease, so the typical spectrum you would expect on a medical ward. Also, we had a high burden of comorbidities, so a lot of patients had cancer, diabetes, chronic kidney disease, hypertension, coronary heart disease, and other comorbidities. So then the first question when analyzing the trial was, well, how well did our algorithm work? Were we able to improve nutritional care in these patients? And on this slide, you see how many patients in both groups reached the energy requirements on top and the protein requirements on the bottom slide. So in red is the intervention group, and in blue is the control group. And by looking at this slide, you see that from day one, we had a higher percentage of patients reaching the energy requirements. So we started with a bit more than 50%, and in the end, more than 80% of patients reached the energy requirements. And very similarly, also for protein, we had about 50% on day one, and we came up to more than 80% of patients reaching their protein requirements. Now, the control group patients had lower amounts of energy and protein. However, also when their disease improved, there was also a slight increase in food intake in regard to energy and to protein. Now, the interesting question is, okay, we are able to improve nutritional support, we are able to improve nutritional outcomes, but does it really translate into better clinical outcomes? Our main endpoint in the trial was severe complications. So it was a combined treatment failure outcome, which consisted of mortality, ICU admission, functional decline, and severe complications. And the power was strongly powered to find a difference of 6% in the risk for combined treatment failure. We also had several secondary endpoints, including quality of life, including functional outcomes, activities of daily living, but we also looked at side effects from the intervention. So here you see the main results of the trial. In red again, it's the intervention group, and in blue, it's the control group. And you can see this is time to severe complication within the first 30 days on top, and time to mortality within the first 30 days on the bottom part. And so we found a significant reduction in the risk for complications in these patients receiving individualized nutritional support. So we had about 27% risks for complications in controls and about 23% in intervention patients, so a difference of 4%. So the number needed to treat was 25 in our trial. So this means if you treat 25 patients during their hospital stay with nutritional support, you can prevent one severe complication. In regards to mortality, the number needed to treat was about 40. So meaning that if you treat 40 patients with nutritional support during the hospital stay, you can prevent 1 death attributable to malnutrition. So this gives you an overview of all the different endpoints. So again, we had significant effects on the risk of complications, which was the primary endpoint. We also had significant effects on mortality. We also found that we had about a 40% lower risk for functional declines. We had improvements in activities of daily living, so functionality improved in these patients. We had improvements in quality of life. And very importantly, there was no differences in any types of side effects. So some patients experienced gastrointestinal side effects, but there was no differences between the groups. So in one word, the results showed us that nutritional support does not have any harmful effect, but is very efficient in reducing risks for complications, mortality, and improves activities of daily living, functionality, and quality of life. So we then further asked the question, well, because it's quite a heterogeneous patient population, is this effect of nutrition on outcomes, is it something that is true for the whole inpatient population, or are there any subgroups which may not show benefit from nutritional support? So we stratified patients based on age, gender, risk for malnutrition, initial body mass index, admission diagnosis, and comorbidities. And we did not find that any of these subgroups really nutrition would not work. So independent of age, of gender, independent also of the risk of malnutrition based on the NRS score and admission diagnosis, nutrition was very efficient in reducing risk for complications. The only subgroup that was significant was chronic kidney disease. And patients with chronic kidney disease had the most benefit from nutritional support. So the effect in this subgroup of patients was even stronger compared to the overall patient population. What are limitations to our trial? Well, first, it's a pragmatic trial, so we did not do any blinding. We also did not have perfect adherence, and this is what we see typically in the hospital when treating these patients, that in some patients it can be hard to reach the targets. So we had adherence of about 82%. Also, it's now interesting, of course, to ask the question, well, what made the difference? Is it the proteins? Is it the calories? Is it something else we had? And because it is a bundled intervention, and nutrition is a team effort with a bundled intervention, it's not possible now to understand whether it's really the effect is protein or calories. But I think in the end, it's really the nutritional approach that is important. Early screening, use of a physiological approach to nutrition, that makes the difference in these patients. So now we have the randomized trial, but our work is now not finished because we still want to look at costs and also to better understand from a mechanistic point of view what are the links between nutritional support and improvements in clinical outcomes. Also, I think it's an interesting question whether we can more personalize nutrition. So currently, we use a similar approach to patients. We personalize, and in our trial, we personalized nutrition and individualized nutrition by making individual goals for patients, which were mainly weight-based. So based on the weight, we had different goals in regards to energy and calories, and also protein. But also today, we don't really have any biomarker which will help us to better stewardship our nutrition. So imagine if you have a patient with hypertension and you use antihypertensive medication, you want to see the blood pressure in this patient as an endpoint, as an intermediate endpoint, which tells you whether your medication works or not. Also, when you treat your diabetic patients, you want to have a glucose measurement or an A1C level to tell you whether you should increase your medication or not. So what is our biomarker for nutrition? It's just a weight maybe, and as you all know, in the in-hospital setting, weight may not be the best parameter because of differences in fluid, which have a strong influence of weight. So here we have a lot of biobank data which may allow us to come up with more precise and specific markers which tell us if our nutritional approach in a single patient is sufficient or not. Second, also, I think it's important to update the guidelines. As I said previously, most of the recommendations today just give weak recommendations due to the lack of strong trial data. So now that we have stronger trial data, I think it's important to update the guidelines and then also bring the good message then to the hospitals, to the physicians, and to the patients, so they know that malnutrition is not just something which we have to tolerate, but it's actually a modifiable risk factors, and with a carefully planned nutritional support team, we can improve outcomes and the nutritional management of these patients. So is nutrition cost effective? And we also started now to look at the costs of the intervention and the effects. And just if you do a calculation yourself, and we estimated that on average the costs for the food products would be around 5 to 10 Swiss francs or US dollars per day. We have some costs associated with the dietitian time. But for a 10-day hospital stay, overall these costs are very low. And then you have very strong effects on clinical endpoints. So clearly we find that nutrition is a very cost-efficient intervention. At low cost, you can have a very strong clinical impact in these patients. Now you may also ask the question, well, why is this trial now so different? How does it fit the overall picture? And of course, when we talk about updating guidelines, it's important not only to look at one single trial, but you have to look at all the different trials to understand what are clinical effects. So we did do a meta-analysis about 5 years ago, and the meta-analysis showed that there is some trials and also some positive trials. But overall, in this first meta-analysis, there was no significant effect of nutritional support on clinical endpoints. But since the publication, there have been several trials. And another very important trial I like to mention is the NOURISH trial. The NOURISH trial was a bit different from our trial in several respects because it was a placebo-controlled trial which studied the effect of a single supplement on clinical endpoints. And also similar to the EFFORT trial, this NOURISH study showed that improvement in nutritional care by use of this specific supplement has a positive impact on mortality. And there was a significant reduction in the risk of death during the study. So now, when you look at all the different trials, and we just did now an update in our meta-analysis, we found that when you look at the total of patients, and now we have about 5,000 patients overall being in the trials, there is a significant reduction in mortality associated with the use of nutritional care. So I think based on these novel trial data now, we really have to see nutrition not just as something we can do on the side, but we have to understand that nutrition is an active treatment which has a significant effect not only on nutritional endpoints, but also on clinical endpoints. And so for patients with malnutrition, nutritional support is really one of these treatments we should start in the patient, because we not only affect nutritional endpoints, the weight of patients, but we really have a strong effect also on the clinical recovery of these patients. So I'd like to conclude by saying that first, the risk of malnutrition affects really a large population of the polymorbid medical inpatient population. It's very important to use a validated screening tool to identify these patients who may benefit from nutritional support. Now, the recent trials, including our EFFORT trial, but also the NOURISH trial, provide high-level evidence that early start of nutritional support is highly effective in reducing malnutrition and its associated complications, including also mortality. So now it's really time to act, and we should no longer just look at malnutrition as as just something that we cannot do anything about it, but we have to act and be more active about nutrition support in these patients. So with that, I'd like to close and hand over to my colleague who will do the second part of the seminar.
Thank you so much, Dr. Schultz. It's my pleasure to be with you today to give you a recap of the ASPEN Congress proceedings and learnings from the Congress. As you know, the Congress is ongoing currently in Krakow, Poland, started on August 31st. The first session I would like to highlight is Nutrients to Influence Muscle Anabolism. That was conducted on Saturday, August 31st. And the faculty included Dr. Phil Atherton from the UK, speaking about mechanisms driving muscle anabolism. Dr. Jean-Paul Thijssen from Belgium, control of muscle mass by myokines IGF-1 and myostatin. Dr. Juan Carrero from Sweden, talking about the prevention and treatment of muscle wasting in renal disease. The session highlighted the anabolic effects of dietary intake of essential amino acids on muscle protein homeostasis, the net balance between muscle protein synthesis and breakdown, especially the dietary intake of the amino acid leucine and its bioactive metabolite HMB, or beta-hydroxy beta-methylbutyrate. In addition to the direct muscle protein synthesis promoting effects of essential amino acid, along in combination with exercise, those could also be explained by the increased vascular flow effect on the muscle of these nutrients. Two chemokines play a major role in muscle loss, especially the glucocorticoid-induced muscle atrophy, and those are insulin-like growth factor, or IGF-1, and myostatin, two targets for potential therapeutic intervention to decrease the glucocorticoid-induced muscle atrophy. There was discussions showing some evidence of the anabolic resistance of the elderly to protein with aging. This to be discussed because there was other session that also said that with aging, anabolic resistance is not a significant factor. However, aging with inflammation, that might induce anabolic resistance. So it's also data showing the effect of pulse versus bolus intake of essential amino acid, and there actually no difference between the two, between bolus and pulse on muscle protein synthesis and degradation. Dr. Carrero, in his topic on the chronic kidney disease and the muscle protein loss associated with it, he started by saying that protein energy wasting is a common disease among patients with CKD, especially those on dialysis, and that he highlighted that actually the renal society should work with the nutrition society on proper or standard definitions of malnutrition. He mentioned the GLIM definition of malnutrition as well. They talked about three drivers in altered muscle synthesis and repair in chronic kidney disease. Those are reduced anabolic drive, reduced dietary protein intake and increased amino acid losses in dialysate, and the myostatin overexpression. And he highlighted also the potential important factor of inflammation driving increased muscle breakdown and the anabolic effect of growth hormone. Therapeutic strategies to increase muscle mass and or function in patients with chronic kidney disease should involve increased dietary protein intake, the use of anabolic agents, and tackling the underlying causes of inflammation-associated muscle protein breakdown. The second session I would like to highlight, that was on nutrition in the older patients. Dr. Antwich from Poland talked about vitamin D and osteosarcopenia, role of exercise. Dr. Muzarek in Canada talked about modulation of chronic disease with fish oil. And Dr. Volkret from Germany talked about frailty, prevention, consequences, and treatment. In the first session, the speaker went through the literature about the role of vitamin D in improving muscle protein synthesis and bone as well. And he talked about that vitamin D receptor almost present in every cell of the body. Thus, vitamin D exerts a pleiotropic effects. Muscle performance significantly correlates with serum level of the bioactive molecule 1,25-dihydroxyvitamin D, and that vitamin D supplementation increases muscle performance, but also exercise increases vitamin D level. There was a debate about the role of sun exposure in people who exercise, especially runners, but he also debated that it's the role of sun. It's actually maybe the direct effect of exercise independent of sun exposure. That's to be determined by further more clinical trials. But he also mentioned that running increases the epimerized form of vitamin D, which is the activated actually activated form of vitamin D, and the balance between activated forms and inactive form of vitamin D. Then he highlighted two molecules in the homeostasis of bone metabolism and muscle metabolism. The first one is HMGP1, and the second is irisin. HMGP1 is an inflammatory protein that increases skeletal muscle degradation. That vitamin supplementation actually decreases the level of HMGP1, which could be one important factor linking the effect of vitamin D on muscle and inflammation. Also, vitamin D stimulates the expression of irisin, which is a myokine secreted by the muscle cell that helps with osteoblast differentiation. The second session talked about omega-3 fatty acids, highlighting the fact that current intake levels, dietary intake levels, do not meet the recommendations for the general public, and that low plasma levels of omega-3 fatty acids is associated with low muscle mass in several chronic diseases and sarcopenia. And the fact that omega-3 fatty acid supplementation, the evidence is inconsistent when you review the literature. There's several meta-analyses. She highlighted also the fact that different types and doses on these studies of omega-3 fatty acids, the sexual dimorphism, the small sample size, focus on inflammation, not muscle mass, compliance rarely stated or measured, length of supplementation is variable, diet is not controlled, assessed, age, gender not controlled for. These are the hurdles of generalizing the effect of omega-3, and definitely more evidence is required in specific areas and diseases. But she also highlighted that omega-3 may help overcome anabolic resistance, and even that could be due to a direct anabolic effect of fish oil or omega-3 fatty acids, independent of its anti-inflammatory effect. She highlighted the new ASPEN guidelines recommending fish oil supplementation in cancer patients, and that actually could be related to direct effects of fish oil on tumor cells, decreasing tumor size. She highlighted some of the evidence that oral nutritional supplements with fish oil was beneficial in lung cancer patients preserving lean muscle mass compared to isocaloric isonitrogenous oral nutritional supplement. And that fish oil decreased chemotherapy-related toxicities in some studies, and the notion about chemotherapy, what chemotherapy is used in which study, that's very important, because we don't have evidence enough for every chemotherapeutic agent, and we should look at the literature as per chemotherapy use. At the end, she highlighted that combination therapy, the multimodal combination therapy, including nutrition, exercise, anabolic substrates for muscle protein synthesis, are likely to be of benefit in cancer patients. The second talk was about frailty, and it went through the multiple definitions of frailty. The speaker talked about Freud score, which is most commonly used in clinical studies, that has 5 phenotypes: weight loss, weakness, slowness, low activity, and poor endurance. And the major drivers of frailty includes aging, malnutrition, disease, sarcopenia, decreased physical activity levels, and anorexia. And that, in fact, frailty is an independent predictor of poor outcomes. In one of the CHS study, more than 5,000 patients aged 65 plus frailty with a significant independent predictor of worsening mobility, worsening activity of daily livings, first hospitalization, and mortality. The speaker mentioned that dietary strategies to address frailty should address potential causes, and those are, in terms of nutritional requirements, lack of energy, lack of protein, especially essential amino acids, vitamin D, antioxidants, omega-3 fatty acids, and that should be tailored for the specific patient deficiencies. In addition to that, to counterbalance the anabolic resistance, strategies should also provide anti-inflammatory, antioxidant nutrients, and provide nutrients with systemic effect on multiple organ systems that have no adverse events and with low cost. Some of the nutrients mentioned in the literature include leucine, HMB, arginine, beta-alanine, citrulline, vitamin D, omega-3 fatty acids, and others. And the conclusion that we need more evidence is warranted to come up with consensus guidelines and recommendations. The next session I would like to highlight was body composition in clinical practice. Professors Milzer, Norman, and Prado talked about the body composition in healthy people, accessible methods of body composition measurements, and the added value of body composition at diagnosis and follow-up in chronic disease. Globally, in 2017, life expectancy was 73, but healthy life expectancy was only 63. On average, we spend 10 years in more health. And in the US, for example, 70% of US adults are obese or overweight. 1/3 have heart disease, 1/5 have cancer, and 1/6 have diabetes. That BMI is a measure of obesity with a high sensitivity and low specificity. It does not measure body composition. And in fact, that was highlighted in many sessions of the conference, that we should stay a little bit away from BMI into measuring body composition, especially muscle mass. Why is that? Because low muscle mass seen across disease states, obesity, pancreatitis, cancer, cirrhosis, COPD, heart failure, and osteoporosis examples correlate with significant decrease in the patient overall outcome. The benefits of assessing body composition in chronic disease, it leads to monitoring the disease progress, monitoring treatment efficacy, body fat, muscle mass, tailoring treatment, tailoring nutrition care, and predict risk or outcome. There are multiple tools now in clinical practice and research setting, the BIA, bioelectric impedance method, the ultrasound, CT, anthropometry. There was many talks actually talking about the differences. For example, BIA most widely used in clinical practice. However, especially for fluid accumulation or fluid interaction, maybe, for example, ultrasound need to be refined. CT, but it's not accessible for a bedside, but it's one of the most accurate measurement tools for muscle mass. Then there was this plenary session with Dr. Delzine presenting her work, and that was the Sir David Cuthbertson lecture. Very fantastic talk. Dr. Delzine received an award from Aspen, talking about 20 plus years of research in the area of prebiotics, especially the inulin type fructans that her lab developed. Inulin derived from chicory roots has a bifidogenic effect, a prebiotic effect. She went through the data as from preclinical, the animal models showing that those inulin type fructans has been shown to exert metabolic effects, to decrease triglyceride, endotoxemia, inflammation, insulin resistance, increase satiety, glucose tolerance, into the current line in human research in humans showing it induces GLP-1, which is important for insulin secretion and optimal glucose production, homeostasis, and that's why it decreased postprandial glucose levels. And the inter-individual variability between the different types of microbiome based on the type of patient and the type of prebiotics call for personalized nutrition, the role of fibers, prebiotics, and probiotics for personalized nutrition. The last session I will highlight is proteins in clinical nutrition. Professor Dutz, Bueri, and Dr. Rice talked about integrated protein metabolism, qualitative needs in clinical situations, and quantitative needs in clinical situations. So the highlights are the current RDA of 0.8 gram per kilogram per day is actually insufficient to meet the protein requirements, and maybe the proposed RDA is 1.2 grams per kilogram per day. And if we do that, actually more people will be diagnosed as protein deficient. There's a synchrony here between this session and the first session I highlighted, talking about SIP versus bolus. There is no difference between the effect of whey or casein protein on muscle anabolism. It is related to the dietary protein intake. Here is the anabolic resistance that I mentioned earlier. They said like older adults, maybe they don't have anabolic resistance, but if you have in critical illness, yes. And in COPD, chronic COPD, maybe no, there's no anabolic resistance. This topic, as we mentioned before, maybe need to be refined as we proceed with research. And that dietary protein intake 40 versus 70, no change in muscle protein synthesis, as if like we're getting to a ceiling effect, like 40 grams of protein, that would give us the maximum protein muscle protein synthesis. Above that, there's no incremental effect. Leucine, there's no additional effect in net proteins anabolism, and HMB is more promising than leucine, that Dr. Dute's slide, highlighting the fact that HMB helps with decreasing muscle protein breakdown. And in critical ill patients, that protein might be, we should attune our clinical practice to the protein rather to calories. And the current enteral formulas might be deficient in protein delivery, and we might need protein supplementation to meet the protein needs. And the recent 2019 evidence say that we get exacerbated, acute exacerbated skeletal muscle wasting in critical illness. In one study showed up to 5% loss in 1.5 weeks. And the session highlighted the difference between ASPEN and ESPEN guidelines. Is it 1.2 to 2 gram per kilogram per day, or is it 1.3 gram per kilogram per day? This is actually necessitate more studies. In fact, there is an ongoing study by Dr. ANHI and colleagues to discuss exactly this area. So hopefully next year we might have some good news. So with that, I would like to thank you, and I would attune to any questions.
Thank you very much, Dr. Schutz and Dr. Hegazi, for that great information. We do have a couple of questions for you in the time that we have remaining. The first one is for Dr. Schutz. Thank you very much for your engaging presentation. Can you talk to us about why you decided to use the NRS 2002 for your nutrition screening tool and not other validated nutrition screening tools?
Yes, this is a great question. So in Switzerland, the NRS 2002 is actually the most widely used score. It's also the one we have recommended by our societies, and so it is standard in most Swiss hospitals. I believe that our results would be similar if we would have used one of the other tools. So I think in the end it's important just to use a screening tool early on hospital admission, your patients, and identify these patients with malnutrition or at risk for malnutrition. I don't think it's so important which tool you use in the end.
Thank you very much. We have a second question for you. Can you talk about how often ONS was used in the intervention group and how often enteral and parenteral nutrition were used?
So most patients were managed without enteral and parenteral nutrition. And so for most patients, we only used oral nutrition. And for oral nutrition, many patients used ONS. So about 90% of patients, ONS was part of the treatment plan. So we always started with hospital food, with between meal snacks and other things. But for most patients, it was difficult, particularly to reach the protein targets. And so the ONS is a really efficient way to increase with little volume the amounts of protein for a patient. And so for some patients, it was just one ONS a day. For some, it was 2 or more. So this was really individual based on the patient's preference also.
Wonderful. Thank you so much. Dr. Hegazi, we have a question for you. Can you talk to us about the information you shared on vitamin D from ESPEN and whether or not we should continue to supplement our patients with vitamin D?
Yes, I think that's a great question. As you know, the data on vitamin D deficiency correlating with almost every disease is there. It's just the effect of vitamin D supplementation this is where we need more evidence. We know that, for example, in prevention of osteoporosis or prevention of bone decay, I think that vitamin D supplementation plus calcium is definitely there. So I think until we have this longer, very good, well-controlled clinical trials, I would advocate for screening for vitamin D deficiency and making sure that our patients are not deficient to begin with. And until we get this homeostasis of vitamin D, I think that would be a good tool for our patients waiting for this very conclusive evidence of vitamin D supplementation beyond if you're normal levels.
Wonderful. Thank you. Dr. Schutz, we have an additional question for you. Another thanks for your wonderful presentation. How can the results of the EFFORT trial be used to improve nutrition care in our hospitals, first? And second, what can we do differently based on the results of this trial?
Well, I think the trial just proves that, you know, what a lot of hospitals and a lot of dietitians are already doing every day actually has very strong effects on clinical endpoints. So when you look at the quality of nutritional care among hospitals, you have some hospitals that are really progressive and already have an active program in place, and others that have not invested in that. And so I think the trial really informs that we should, in all hospitals, start to look for malnutrition. And if we have patients that are affected, we should be active regarding the nutritional approach. And so the trial also, I think, is an important proof also for the hospital management, for the payers, that, you know, it's very good invested dollars if you invest them in dietitians, in nutrition, because there is definitely a payback.
There's a follow-up question there as well. So can you talk about the role of the dietitian in your study and how that impacts the work that you do in your hospital?
So I think the dietitian really is instrumental and was instrumental in our study and is instrumental for nutritional care. So we organized in our hospital that the screening was primarily done by the nursing team, but for patients that were flagged to be at risk, then the dietitian came to the patient and they did an assessment with the patient, and they also came out with the nutritional treatment plan. And the dietitian visited the patients every 1 or 2 days to see whether the nutritional plan was working. So nutritional support is complex. It takes time and it takes a lot of effort also with the patient. So it's not just about putting an ONS on the table and leaving the patient, but it's really about engaging with the patient, explaining the importance, and making sure that the patient is on board and he really consumes all these nutritional products.
Thank you. It's very interesting how you described so well the multidisciplinary effort that your team undertakes. Dr. Hegazi, we have another question for you. Can you, for the information on body composition, can you discuss how you think we can incorporate into nutrition care in the hospital if we don't have access to BIA or ultrasound or CT?
Yes, I think that's a very clinically important question. For example, in the US now, the dietitians incorporate what we call nutrition focus physical examination in their assessment of nutritional status that include looking for muscle depletion. And I think this is a great advance in the way we utilize our resources, and this is the very important role, to Dr. Schultz's point, of dietitians. So instead of just looking at the patient dietary intake and the requirements, they also have now the leverage to assess the muscle in patients. So I think until we have a more consistent and valid tool of assessing muscle mass, and accessible tool for assessing muscle mass or body composition in the clinical setting that's not affected by fluid overload or fluid status, I would advocate that we start looking for muscle mass depletion, the physical science of muscle mass depletion. If there is a hand grips tool, the dynamometer, if you can use it, And hopefully in the future we're going to have accessible, more easily to use, like either ultrasound or BIA in the hospital.
Thank you. We have just a couple of minutes left. For either of you, do you have any closing comments, learnings from the session, anything that you would leave for those who have called into the webinar today?
I would go by saying that the role of protein and muscle was very, very highlighted in this conference in multiple sessions, and it's in the right direction. Our understanding of malnutrition from just tools of dietary intake and deficiencies into the role of muscle, even the BMI, staying away from BMI as a marker for health, into the low muscle mass. I think this is very good and we're in the right direction. Dr. Schultz, do you agree?
Yes, absolutely. I think it was a very informative conference, and I think more and more we now move to a better understanding how individual patients with malnutrition are affected. So malnutrition can have different phases. Sarcopenia being one of the very important complications, and I think a lot of sessions now have also highlighted that we can be active about it. And it is actually a treatable disease, and we can have a positive impact on patients. So I think it was a very important conference highlighting these points.
Wonderful. Thank you both for your presentations today and for the insights that you shared. This concludes today's ANHI webinar, and we look forward to having you join us for our next one. Thank you.